good. Most of our science was level 4 and 5 studies, which, when it comes down to it, is not the best way to determine how to treat, how to manage the things we see. We've gotten better over the years. At least we're keeping track of the levels of evidence, and we're trying to base most of our decision making on higher level studies like 2s and 3s. The level 1s are a little hard to come by. This is a simplified schematic view of the knee showing the 4 ligaments. I think we all know that it's a little more complicated than this, and that's one thing I really want everyone to make sure they take away from this talk is the complexity of the ligament structures. So, sort of like this photo here, the MCL is not just a simple strut between the femur and the tibia. There's more to it than that. We'll get into it a little bit more, but we really talk about the posterior medial corner when we are talking about significant medial-sided injuries. All right, just making sure my pointer is working. So I'll get into the structures on the posterior medial corner, but it's more than just a simple superficial MCL. Similarly, the LCL is not just a simple fiber between femur and fibula. There is the posterolateral corner, which we need to understand. The PCL, there are 2 bundles that we talk about, and this becomes important when we reconstruct the PCL. The anterolateral bundle and the posterior medial bundle. One of the mnemonics for that, if you haven't heard it before, PAL for posterior cruciate ligament. PAL, P-A-L, you have an anterolateral border bundle and a posterior medial bundle. The ACL would be the opposite, anteromedial and posterolateral. The ACL does have 2 bundles that we talk about, but then there's also this question about the ALL, the anterolateral ligament. Anyone heard of that? Anyone heard of the anterolateral ligament? Show of hands. Just a couple. It's been in the news in our literature, so you'll hear a little bit more today. Thanks. So back to the MCL, the medial side of the knee. There is the superficial MCL, and deep to that is the deep MCL, which is an expansion of the capsule. But really what we talk about is more posterior-medially. We have our posterior oblique ligament. We have our capsule, we have our semimembranosus hamstring tendon, which form the posterior medial corner, which is very important when you get these higher level injuries. Most of us know an MCL injury occurs from a valgus force, usually a contact injury, as opposed to a ACL injury, which is typically about 70% non-contact. Our MCL is most commonly a contact injury. Medial-based pain, they may have difficulty with weight bearing. If there's, I think this is important, if there's no additional injury, if it's a mild to moderate MCL injury, there shouldn't be an effusion. If your patient has an effusion, a hemarthrosis, then something else is going on. If they're lucky, it's just a significant bone contusion on the lateral side, but it's a patient that probably needs more workup to evaluate for cruciate injury or meniscal injury. So these patients will have pain and laxity to valgus stress testing, in particular at 30 degrees of flexion. Our grading system is pretty simple for these, similar to some of our other injuries. Grade 1 is a simple sprain of the MCL. There may be tenderness. There is tenderness along the MCL. There shouldn't be any significant laxity, although it may be painful for you to do a valgus stress to your athlete. Grade 2, somewhere in the middle, there is some laxity, but there's an end point. So you crank on the knee, it gives back a little bit. It doesn't just keep on going. This is tearing rather than just sort of stretching of your superficial MCL. But the grade 3s are the ones we worry about more because these may need surgery. There's significant tenderness and swelling. There's gross laxity. So you put them in 30 degrees of flexion, you do your valgus stress, and the knee sort of just keeps on going. There's no end point, and they will have, oftentimes they will have some laxity in extension. Something else you can start doing is checking on your drawer tests, anterior and posterior drawers. Do they have a rotatory instability? What we mean by that is if you do your anterior drawer, you can do that also with internal and external rotation to check the corners. If you do an anterior drawer test with the foot externally rotated, you're testing the posterior medial corner of the knee. If the knee sort of just keeps spinning out or you have more laxity than you did on your standard neutral anterior drawer, you need to suspect a posterior medial corner injury. So what do we do for these? We do our usual protocols of Rice, protected weight bearing if needed. Do we immobilize them? That's been studied in a lot of the injuries that we see, and the answer is we probably shouldn't be, or not for any significant amount of time. Many studies have shown that when we start early range of motion, we get an increased collagen mass, improved biomechanical properties of the healing tissue. So we really ought to start early range of motion. The bad grade 3s that have other injuries, I'll put them in a knee immobilizer. It's a little more humane, and they may need to be in that for a couple of weeks. But the grade 1s and 2s absolutely ought to start range of motion right away. I like the hinge knee sleeve. Has a hinge, but it allows them to really establish full range of motion pretty early on. Return to play. I use a relatively simple system a lot of us use. Grade 1s can go back to play in 1 to 2 weeks. Sometimes they'll even play that day. Grade 2s, 2 to 4. Grade 3s, 6 or more weeks, especially if they have additional injuries. A decent study in 2009 evaluated grade 3s. 75% of grade 3s had an additional injury, and most commonly, by a wide margin, it was the ACL. So what do we do if they do have a grade 3? Certainly if it's combined with additional injuries, we like to reconstruct those. Reconstruction versus repair, meaning we are actually putting a new ligament in there. We are not just repairing the tissues back together. There's different ways to do it, but more and more what we are doing is trying to incorporate not just our MCL, but the posterior medial corner. There's a graft going towards the back here, and in this case, the hamstrings are used and brought back around behind the semimembranosus, sort of as a sling, and that little triangle there incorporates your posterior medial instability. So, which is better? This is a little bit of a debate in the orthopedic conference rooms. Should we repair the MCL, or should we actually reconstruct it? There was one level 2 study, which is a decent study, showing that if we reconstruct, meaning put a new ligament in there, that there are better objective results with reconstruction, but the subjective results, what the athletes were reporting to you, really were about the same. There's some anatomical studies as well, which didn't really give the answer either. So the bottom line is we don't have high-level evidence to support reconstruction over repair on the medial side of the knee. Many surgeons will tell you that they prefer to repair a structure, certainly the medial side, when it's a new injury. If it's in the first week, 2, maybe 3 weeks, you can repair it, you sew it back together. If it's after that, it's more chronic, the tissue quality isn't so good, it's more difficult to repair these things, they retract. So at that point, reconstruction is considered a better option. If something's ripped off the bone rather than torn in the middle, it's easier to repair it as well. That's an avulsion. If you can repair the avulsion back to the bone, that's easier and probably stronger than repairing it in the middle. So in the chronic situation and subacute situation, and sometimes in the acute situation, we will opt for a reconstruction. Let's go over to the lateral side. So it's the posterolateral corner that we need to be familiar with. This has been well mapped out with anatomical studies. Yes, we have our LCL, can't see that well, connecting femur to fibula. We have our popliteus tendon, and we have our popliteal fibular ligament. In addition, you have your lateral gastrocs in the back. This used to be called the arcuate complex. So this is a less common injury. In part, just the mechanism is a varus force. Getting hit on the inside part of your knee is less common than getting hit on the outside part of your knee. So MCL type injuries are more common. It can occur with a hyperextension injury as well. Usually it's in combination with other injuries. It's less common to see the lateral side of the injury compared to the medial side. Don't forget about the other injuries. When you have a significant injury like this young man, his peroneal nerve is at very high risk, as is his popliteal artery. The exam, lateral sided swelling, tenderness over the LCL. Usually in a normal knee, you can palpate the LCL if you're in the figure 4 position. In these patients, it's boggy over there and you can't feel it. They have laxity to stress in 30 degrees of flexion and in extension if it's a significant injury. The dial test is something we like to do. Usually we'll do it with the patient prone in 30 degrees of flexion. We are spinning their feet externally. It should be symmetrical. If it's not, like this one, then you have to suspect a posterolateral corner injury. Management, this is also, for the most part, grade 1, 2, 3. Similar in terms of grade 1s and 2s. I think grade 2s are rare in this scenario. You'll see an occasional LCL sprain like a grade 1. But when there's a PLC injury, it's usually in the high energy mechanisms. When that's the case, or repair posterolaterally. So here we are, we have an MRI. This is a normal knee here, just so you're familiar with the anatomy. We have our LCL coming from our lateral epicondyle to our fibula. Over here, this is your popliteus tendon, which inserts on the femur here, and it comes behind the knee, and then it disappears. It'll be behind the fibula, behind the tibia here. But it's important to look for that. On this side, this is a right, this would be a left. Your LCL is torn. There's a lot of white edema over here. There's been an injury. You don't see where your LCL attaches to the fibula, and you don't see the popliteus tendon here. So repair versus reconstruction. This has been studied pretty well. There are some decent studies out there, level 2s and 3s by the gentleman mentioned at the bottom here. Classically, if you get to these early, we would repair these as well. Repair the lateral side if you get to it in the first 3 weeks. Chronically, you need to do a reconstruction. Standard challenged this in 2005, as he noted that some of these repairs just don't do that well. So they compared reconstruction versus repair and found a much higher failure rate in the repair group compared to the reconstruction group, 4 times higher. And amazingly, Levy had a very similar percentage of failures in his study. And the interesting thing about this study, I would say, is that they cherry-picked these cases. So the ones that looked ideal for repair, good tissue, patient, healthy, avulsion, you should be able to repair that. And that's what they did compared to the reconstructions, which were the worse off patients. And yet, they still had a higher failure rate in these cherry-picked cases. So with this information, many of us go right to a reconstruction no matter what the timing is. For instance, this is a patient who was hit by a car, and you open the skin, and this is what you see. There is no dissection here. This is basically, you're looking right into the knee joint. Everything has been destroyed. Here's your lateral meniscus, but we have lateral capsule, we have our, where's our LCL? Where is our popliteus? It's a mess. Yes, we can repair this back to the tibia, and we did with anchors, but that needs more. That tissue's all been stretched and destroyed. That needs more. I believe that needs a reconstruction. How do we do that? Well, the trend over the past 10 years has been to do things anatomically. So Laprade and others have studied where do these ligaments go, where do they come from, and how do we reconstruct those. And so we've learned that to reconstruct it, we have to really map out precisely the origins and the insertions. And this would be one of the techniques. So does this work? Yeah, this is better here. So in this case, we have 2 ligaments, 2 grafts that we use to reconstruct PLC. You're looking from the side of the knee. The patella would be in the front over here. Here's your LCL going from femur to fibula. Okay, but then that's drilled through the fibula, and it comes back around and through the tibia. The popliteus comes from femur behind the LCL and comes back through the tibia this way. Looking from behind, here you see your LCL, but it comes through the fibula to the tibia and out the front. Here's your popliteus. So with that, you've now reconnected the femur to fibula, the fibula to tibia, and the femur to tibia. Moving along to the PCL. So we have our PCL. Here's a video by Laprade, which is where Dr. Buckley studied out in Colorado. And I just want you to see some of the bundles here. So we have the posterior medial bundle and the anterolateral bundle. This is looking from behind. And it is just to show you that there really are 2 bundles. If you cut it down microscopically, there's like 1,000 bundles. But we do divide it up into 2 bundles, and they have different positions and functions. And when we reconstruct reconstruct the PCL, many will perform a double bundle reconstruction rather than a single bundle reconstruction. So here you see it pretty well. You have your anterolateral bundle and then your posterior medial bundle. Okay, in this case, this is a MRI of a normal knee. This is what the PCL should look like. Okay, but with a PCL rupture, you just don't see it. Mechanism's different here. Typically, this would be a direct blow to the proximal tibia. Oftentimes, a linebacker getting hit by the fullback coming out of the backfield. It could be a helmet to the knee or dashboard to the knee in a motor vehicle accident. But hyperextension and hyperflexion mechanisms are well described. It's not as dramatic an injury, and oftentimes as a result, it can go undiagnosed for years. Players can actually play with this and not even know they really had a significant knee injury. An isolated PCL injury on exam, they will have full motion and they can do a straight leg raise. They may just come walking into the office, but they will often, if it's an acute injury, have pain with hyperextension. In a more chronic or significant situation, they'll have this posterior sag to the front of the tibia. A posterior drawer is the most common exam that we utilize. Importantly, don't get fooled by the false Lachman's exam. If you perform your Lachman's and the tibia is posteriorly subluxed because they've torn their PCL, when you perform your Lachman's, you're going to think you have anterior translation. But you don't, because the knee wasn't starting where it's supposed to. So start the knee where it's supposed to be, and then test your Lachman's or your anterior drawer. So you can get there, because if you have a significant PCL injury. They shouldn't have varus or valgus instability if it's an isolated injury. And don't forget about rotation. Whoops. So grading, also a 1, 2, 3, and this is based on where the tibia sits compared to the femur. It should be anteriorly. Normally, the tibia sits anterior to the femoral condyles when you're in this 90 degrees of flexion. You can feel that on yourself. Your tibial tubercle is sort of a little more prominent than your femoral condyles. If you have grade 1 injury, it's still, even in posterior drawer testing, it remains anteriorly positioned compared to the femur. So that would be less than 5 millimeters, that would be a grade 1. A grade 2 is about 5 to 10 millimeters of instability, and you can displace the tibia to make it even with the femoral condyles. A grade 3, more instability, you can push it posterior to the condyles. Why does this matter? Well, it does matter in terms of how we treat these. That's why we try and have these grading systems. Grade 1s, minimal translation. We rehab them till their pain's gone, their swelling's gone. They can get back on the field pretty quickly. Grade 2s have a more significant injury. It may take a little longer to get them back on the field. But that's also a non-operative injury. Grade 3s, it's a more significant injury. It's going to take them longer to get back on the field. They probably will be in a brace for a period of time. Many have said that it's unlikely or perhaps even impossible to have an isolated grade 3 injury. I don't feel that's true. I feel like I've seen it with some of our football players, but it is less common. So what do we do for these surgically? We reconstruct them. Again, like similar to the ACL, you're not just repairing the tissue back together. You need to reconstruct it. You need to put a new graft in there. You can use autograft or allograft. This is a more demanding surgery than ACLs. It's more risky. In part because of the location of the popliteal artery compared to where we drill our tunnels in the tibia. So there are some controversies with PCLs. These really aren't that common. It's nothing like the ACL. Much less common. We have much less data on how to treat these. But what do we do with grade 3s? Can we treat them operatively or non-operatively? Single bundle versus double bundle? Transtibial, meaning all arthroscopic, or do we open this up and reconstruct it that way? There isn't any great level 1 or 2 data, so we don't fully have the answer here. As far as single and double bundle go, Dr. Buckley likes to do a double bundle. I tend to do a single bundle. I would support him in that some of the data does lean towards perhaps better stability with a double bundle reconstruction. The ACL. So as we know, a relatively common injury. Important to remember that this is 70% of these are non-contact injuries, much more common in females than males. Meniscal injuries are common, perhaps as high as 50%, maybe a little bit less. So our ACL anatomy here, this is coming from the front. This is our lateral side. So we have our anteromedial bundle and our posterolateral bundle. This became a hot topic. When I was in fellowship, there was no anteromedial bundle, posterolateral bundle. We just did ACL reconstructions. Pretty much the day I graduated, they started talking about this, and we had to do it a whole different way. But fortunately, as we'll get to, that hasn't turned out to be necessary. So, what are the risk factors for ACL tears? This has been studied, and it's nicely reviewed. If you're looking for a nice review on risk factors, this is a two-part study in sports health, but it goes over all of these risk factors. We know female gender is a risk factor. We know there's a lot of families who have multiple kids with ACL injuries. Some anatomic considerations that we can measure, notch width in the knee and the posterior tibial slope is a hotter topic these days. ACL size does matter. Ligamentous laxity. Patients who are really flexible have a higher rate, as do patients who are heavier. Jump landing mechanics matter. Hormonal considerations is always a topic of discussion. And then playing surface doesn't get all that much press, but I think it probably should. Here we see a few of these risk factors. Jump landing mechanics. We like people to land in that athletic position, not in the knock-kneed, unstable position. We can help that with some of our ACL prevention programs. Ligamentous laxity, posterior tibial slope, notch width, ligament size, these all matter. So who gets re-injured? Re-injury, unfortunately, is relatively common. Depending on the study, it can be as high as 30% of the athletes will have a re-injury of an ACL in the next 2 to 5 years. Unfortunately, or fortunately, that actually is often the contralateral knee. About half the time there, it's the other knee that tears the ACL. Much, much higher with allograft usage, which we've gotten away from after learning some of this data. And we know that now, based on many high-level studies, that the highest risk for injury and re-injury is the young, active female in cutting and pivoting sports. What are the myths and controversies as far as ACL goes? Well, double bundle, as I mentioned, is that better than single bundle ACL reconstruction? How about the anterolateral ligament? I mentioned that earlier. Is our knowledge or lack of knowledge of this the reason why certain ACLs fail? And what about ACL suture ligament augmentation? Can we repair the ACL? Can we put a scaffold in there to allow it to repair itself? Well, as far as double bundle and single bundle go, this has been studied. Someone here was from Pittsburgh, one of our new therapists. So Freddie Fu out in Pittsburgh sort of popularized these studies, and 10 or 12 years ago, it was the craze that we ought to be restoring the anatomy and do a double bundle ACL, since that's what God gave us. And it sort of made sense, but many studies have shown that, including this level 1 study, as I said before, it's not that easy to get level 1 studies, randomized prospective controlled trials. Decent number of patients, good follow-up. They found no difference in subjective or objective scores, and no difference in arthritis at 5 years. So, and most studies would agree with this. There are a few that show perhaps better ligamentous stability with KT-type testing, but no subjective difference. So for the most part, we continue to do single bundles around here. How about the mysterious anterolateral ligament? So this comes and goes in the literature. In part, the reason we think about it is this second fracture. Certain people tear their ACL, and on the x-ray you'll see this little avulsion fracture right there. And it's always a curious thing to talk about. What is that? What's getting ripped off there? Doesn't matter. We don't see it that often, but when we see it, you start to think about it. So the ALL is a capsular expansion that runs from the lateral epicondyle to the lateral tibial plateau. And it was described, as I mentioned, second, but it was being described before that in like the 1850s. It may play a role in pivot shift and rotatory stability. And now some people are recommending reconstruction of that ALL when you do an ACL. This sort of exploded in our literature after the New York Times published their article in 2013. This was summarized by Morose last year. And he showed that up till 2012, there were 0 articles about the ALL. And then in 2016, there was 1 related to this. And then the next year, 45 articles. And so every patient, and if you're on social media, everyone thinks that the doctors aren't too bright. They don't even know that this ligament existed. They should have been fixing this. That's why their ACL failed 6 times. But none of these studies were good studies. They're all level 4, level 5, nothing randomized, nothing prospective. And so there was a lot of push to do the ALL reconstruction, and yet we didn't have good data. Sort of just to exaggerate the point, this expert group of ALL doctors met in Europe 2 years ago and started to discuss what should we be doing with the ALL. I found it somewhat humorous. This expert group majority were paid consultants by one certain company that loves to push these types of things. If we have to fix 2 ligaments and not 1, then we have to put 4 screws in and not 2. So they like to push these things. And I don't know who called these guys experts on the ALL. However, it's worth reading because they do go over all the literature, and you can learn a bit about the anatomy. The ALL actually does appear to be a distinct ligament. Interestingly, it's 2 times as thick in males than females. So perhaps that's part of the reason why females tear their knee more often. It appears to be a secondary stabilizer biomechanically to internal tibial rotation and the pivot shift. In patients who tear their ACL and their ALL, they may have an increased pivot shift. However, the studies that talk about that do not discuss confounding factors such as meniscus tears and tibial slope, other things that we know contribute to instability. So we can't say on that. The conclusions of this paper were that ALL reconstruction has not been shown to improve clinical outcomes, but it is something we're starting to talk about, especially in the patients who are at high risk for re-tear. I did find one good study on this, or seemingly one good study, from a couple years ago, and they had they described this as a prospective level 2 study comparing ACL alone with hamstring, ACL alone with tendon, ACL, hamstring, ALL reconstruction. And they showed that the rate of graft failure if you reconstructed the ALL. And there weren't any increased complications, no increased infections, no increased stiffness, some of the things we worry about. So their conclusions were that ALL reconstruction should be considered high-risk athletes. However, this is a good example of being critical with the literature. On their abstract, it's a level 2 study, and they say it's prospective. In their conclusion, they discuss the limitations of the paper, as we always do, and they describe it as a retrospective study. It's level 3, it's probably a level 4 study. I don't even know how that got published that way. But despite all that, it is information to help us, and we are starting to consider ALL repair, reconstruction, who could benefit from it, because we do, as we know, have a subset of patients who fail their ACL multiple times, and we can't always explain why. Finally, winding down here, ACL repair with suture augmentation. There's a couple other terms for this: internal bracing, bridge enhanced ACL. Basically, can we repair the tissue that is there when someone tears their ACL, and can we augment that tissue instead of taking all that out and putting a new ligament or tendon in? They've tried this over the years. Part of the reason we do a reconstruction is repairing the ACL failed at a high rate back in the 80s and early 90s. And then there aren't any good studies to really tell us who can benefit from it. But a systematic review of these poor studies showed that if you are going to do this, if you are going to try and repair the ACL back to the femur, a braided suture is better than a monofilament suture. Early repair better than late repair. Skeletally immature heal better than mature. And mature we mean like 17, 18, 19. The younger patients heal better. And then proximal avulsions better than mid-substance. Sort of all common sense as far as we can tell, because that all just makes sense. However, we still don't have great data to say that we should do this. As a matter of fact, this study from this year level 3 study where the ACL avulsions were repaired compared to quadriceps autograft. Once again, almost a 50% failure rate for repair versus more standard failure rate for an ACL reconstruction. That's repair. But what you're going to hear about a little bit more is this technique, the Bear technique out of Massachusetts, the Bridge Enhanced ACL. They repair an avulsed ACL, and then they add a scaffold and add whole blood, more so than PRP, as a means of trying to let that ACL heal. In the pig model, it's shown good biomechanical and clinical results, and now human trials have begun. So there actually is some promise here, and I'd keep your ears open for this one. Real quick, I know my time is up. Multiligamentous knee injury. Don't want to talk about ligament injuries without talking about knee dislocations. Yes, you can have one torn and still dislocate, but more likely you've torn multiple ligaments. They can be high, low, or ultra low velocity. So ultra low velocity would be an obese patient who slips off a curb and dislocates their knee. Doesn't seem possible, but unfortunately we see it frequently, and that's a devastating injury that shouldn't be minimized. Those patients have a high risk for complications and need to be hospitalized. For these reasons: perineal nerve injury, 25% in all comers; popliteal artery injury, as high as 30%. So anyone like Zach Miller here who you think has a very loose knee, maybe they spontaneously reduced on the field, but if they have a very loose knee, have a high, low threshold for getting these patients to the ER. They ought to be monitored overnight in case they do have an artery injury. What are the controversies? Real quick: operative versus non-operative, early versus late repair, reconstruction, and if you are going to operate, do you do it staged or all at once? Sometimes these aren't good candidates for surgery. They're not healthy. They're very sick for other reasons, from their injuries or trauma. But if you operate, they're going to have a better outcome. Lice home scores, 100 would be a normal knee. When you operate on them, you can get them up to 85, which is pretty good. That's only about a B, but it's a lot better than your D or D plus with this non-operative treatment. So we do have to stabilize that knee. Do you do it early? Do you do it late? 3 weeks tends to be the mark. And most of the literature starts to favor early reconstruction. Perhaps we wait to do the ACL later so they don't get too stiff. And again, as we spoke about before, reconstruction of the destroyed tissue appears to be better, certainly for the lateral side, rather than repair. And that is it. Thank you very much.